This particular SVT is WPW. So we have now completed our discussion of multifocal atrial tachycardia. I have noted to you the specific points that distinguish it from the others. In WPW, take a look at this heart, and right off the back, this explains everything that we need to know for WPW. We began this discussion some time ago. We'll continue repeating this, and now we have the following discussion. First and foremost, you're paying attention to the green electrodes in the heart. In other words, those nodal areas where the green becomes quite important. This is normal, the green. You have the SA node in the right atrium and then travels to the AV node. You see that circuit right there. And you see that green node? That green node represents the AV node. Every single impulse originating from the SA node should travel through there. There should be a little bit of a delay. I am purposely emphasizing delay. Why? In a little bit, there are certain drugs that you want to avoid at all costs in WPW. And that point of me reiterating delay is huge. Now, where the pathology is what you're seeing shaded in the brown. That is an accessory pathway. That pathway should not be existing, ladies and gentlemen. Because that pathway exists, that pathway right there does not have the characteristic feature of being able to delay your impulse traveling from the atria down through your ventricle. Now, what I'm going to do is get straight to the clinical points, because you can spend hours, days, weeks, what have you, on WPW. We don't have the luxury of that kind of time. All we can do at this point is simply figure out, this is my patient walking in. Take a look at the EKG. No doubt it's WPW, okay? And then after that, well, you get into as much detail as you wish. Education is, as you know, endless, and it's absolutely enriching. But you must lay down the foundation first. So that pathway, accessory, that you're seeing there in the brown shaded area is what you're paying attention to. It doesn't have the delay characteristics, so therefore, any impulse that might then travel through it, guess what? It's going to go through it way too quick. Listen to what I just said. It passes through there too quickly. Okay? So what does that mean to you clinically? What does that mean to you in terms of an investigation known as your EKG? It's the fact that your electrocardiogram, where an impulse from the SA node may then be traveling through your atria and then into the ventricles too quickly, is, what's that by definition? Good. PR interval, right? On EKG. So that PR interval, once again, you tell me what normal is. The time is 0.12 seconds or 120 milliseconds to 200 milliseconds, aka 0.2 seconds, right? If it travels through there too quickly, what have you done to the PR interval? Good. Shortened it. Is that clear? Completely the opposite of what? Completely opposite of what? AV block, right? All those AV blocks that we talked about, ladies and gentlemen, that PR interval, mostly, those PR intervals and AV blocks were prolonged, right? What was the one big exception? Mobitz type 2 under second degree AV block. Do you remember that? If you don't, might be a good time to make sure you review that. This is the time to solidify and distinguish each one of your arrhythmias. So far, your focus is where? On that shaded area, that accessory pathway, impulse traveling through there too quickly, our first real diagnosis where the PR interval has been shortened. Are we good? Less than 0.12, and that's what you're looking for. Next, well, what is this called? It's called the bypass tract. You call this a pre-excitation syndrome. So if by chance you don't see the term WPW, Wolff-Parkinson-White, then the other names for this would be a pathologic accessory pathway disease or a pre-excitation syndrome, which is exactly what it is. Now, are we done? So far, we have one component of WPW. There are going to be two others, and those two will be related, as we shall see moving forward. Well, how would one develop WPW, Wolff-Parkinson-White, a congenital issue? What's happening? Instead of the impulses traveling through the AV, it'll then bypass. Bundle of Kent is something that you want to perhaps keep in mind anatomically, please. Memorize that. Causing earlier ventricular activation. What happens to your pre-R interval? Good. It gets shortened. It is one pre-excitation syndrome. Keep in mind, as you move on into subspecialties or specialization in general, you will talk about many reentry, but at least know one before this course is over. And know it well, all right? Know it well. It could be associated with AFib. Imagine, reentry, in a circle. You're not going anywhere, and you keep coming back in the atria. The atria doesn't know how to respond, and so therefore may lead into atrial fibrillation, okay? Atrial flutter or hypertrophic cardiomyopathy. So it could result in many issues, beginning with WPW. Epstein's anomaly of the tricuspid valve. Well, with this, especially with lithium. So you have a patient who might have bipolarism, is taking lithium, right? And lithium, as well, there are a number of theories out there. Remember, as far as medicine is concerned, for the most part, if it comes to actual official questions or if people are looking for actual definitive and confirmation, it's not based on theory. It has to be confirmed. So you could take a look at the number of theories in terms of mechanism of action, lithium. Please do so. But there's one that you definitely want to know for lithium, and it's a fact that, well, as a side effect, Epstein's anomaly, but more importantly, lithium could work down the collecting duct. Okay? And so therefore, one of the things that you're worried about with lithium is the fact that it could result in what kind of issue? Could be lithium toxicity. Okay? It could result in lithium toxicity in two different places, either tricuspid in the heart, and please do not forget lithium toxicity when dealing with the kidney as well. And down in the kidney, lithium in the collecting duct, the principal cells, it can replace that sodium channel. So I want to go down to collecting duct. This is important. Pay attention. And that lithium, we're doing everything at the same time, integration. The lithium then substitutes the sodium channel of the ENaC on the apical membrane. Are you there? Apical membrane facing the urine. Lovely place to be. Look at the urine passing through. That's where ENaC is. That sodium channel could be replaced by lithium, and if it accumulates inside your cell enough, you could have damage to the kidney because it's not a good, it's not a substitute for the sodium of the sodium potassium pump. So if I were you at this point, I would switch over to lithium and make sure that you understand the two major toxicities up in the heart with the tricuspid known as Epstein, and then down in the kidney where you might have lithium toxicity. This would be a good time to do it, ladies and gentlemen. Let's continue with WPW. Okay, so we have palpitations, dizziness, syncope. I mean, really? Could I repeat this any further? It's the fact that once your heart starts getting dysregulated, that you're not having proper cardiac output. There's no proper organization of blood flow. So therefore resulting in dizziness, syncope, not good, palpitations.